Support for Nevada Week is provided by Senator William H. Hernstat, Cashman Equipment, DeCastro Verde Law Group, Valley Electric Association, and additional supporting sponsors.
Welcome to Nevada Week. Thank you for joining us. I'm Casey Smith. We are continuing our discussion of affordable health care on this show. We want to try and cover all levels of policy related to affordable health care on the federal and state levels. We're also going to talk about policy making or changes that our local healthcare system, even local businesses, can make to increase the affordability and accessibility of healthcare for all of us. With us once again, Heather Korbulik, the Executive Director of Nevada HealthLink, Dr. Julie Kochevar, Ph.D., Administrator for the Nevada Division of Public and Behavioral Health. Also, State Senator Pat Spearman, the Chair of the Senate Health and Human Services Committee, and Dr. Randall Christensen, MD, MPH, the Chief Medical Officer for Nevada Health Centers. Once again, thank you all for joining us. Very, very important discussion we're looking forward to.
Thank you.
Okay. The midterm elections are over.
Yes.
We hope. Okay, there's a few lingering things going on around the country, but for us, they are. So what are some of your takeaways regarding how healthcare factored into or didn't factor into local, national campaign strategies and election results? And Senator, I'd like to start with you.
Well, you know, I think the people who thought that it would not factor in woke up and realized the day after how badly they miscalculated. Healthcare and affordability is on everybody's radar, especially when you start talking about pre-existing conditions, when you start talking about children with asthma, when you start talking about the fact that if you don't cover pre-existing conditions, that may or may not mean that someone who's had a very rough first pregnancy may not be able to get coverage. And so affordable health care played a very large role in the midterm elections, not just here, but I believe across the country.
And while politicians are watching some of the races for the results, you're also watching for the results because policies could change depending on who is elected or what type of issue may be passed. What's your take? First of all, Heather, I'll start with you.
Well, I think it's clear that healthcare was the #1 issue, not only just in Nevada, but across the country in voters' decision making. And the voters spoke clearly that they want their healthcare protected. They want to be able to get access to insurance regardless of their pre-existing conditions. And I mean, really what we've learned is that it's very hard to take away something from somebody that you've already given to them. And people have the ability to have affordable, quality health insurance, and we don't want to go backwards.
My training is in pediatrics, and the American Academy of Pediatrics and pediatricians across the nation, we spend several weeks, several months a year in Washington, D.C. telling everybody how important it is for children to get appropriate health care. Then you start talking about seniors and you start talking about other folks in our community. You will not have a healthy, happy, wealthy community unless you have health care and good, appropriate health care.
And Julie, Medicaid, you deal with the national and the state level.
Right.
How was the outcome? Was it good, bad?
Yeah, I mean, I think we feel really positive. I think one of the concerns in the past had been that it would be repealed, that the ACA would be repealed. There was a big push last summer for repeal of ACA, and now I think the chances of that are pretty small. So that makes it a lot easier for people to have confidence that their insurance isn't going to go away, that for providers to have confidence that people are going to have insurance and they can build systems around providing health care. So I think that is a big change.
Okay, since the election, newly elected officials, Governor-elect Steve Sisolak, okay, Senator-elect Jackie Rosen, Congresswoman-elect Susie Lee have all said affordable health care is a top priority of theirs. Now, do you think we'll see any major changes, or how do you think that'll play out? And once again, Senator, I'll start with you because you're kind of more in the know.
Well, that's debatable, but I think that what they have said is absolutely right, and I know all three of them, and if they said it, I believe it because I know that they will do it. Something about healthcare, affordable healthcare, it covers a lot of different spectrums. You know, Richard Whitley shared something with me that I hadn't even thought about, and that is those states that expanded Medicaid actually saw their citizens' credit score go up. credit scores went up, exactly, and the bankruptcy rate went down. You know, and part of that is because a lot of people, if they have a high medical bill and they can't pay it, then you know you can't pay it this month, and then you got 18 months later, and now your credit score is a -2. So when you have affordable health care, then that makes a difference. The other thing that I know that they are taking with them to Washington is the fact that when we talk about having people insured, it's much like I used to say when my first car, a 66 Chevrolet Impala, I had to make sure I got the oil change because I didn't have enough money to replace the engine. And so affordable health care actually across the board helps not just consumers, but it helps hospitals, it helps businesses. It's just good for everybody. So I have no doubt in my mind that they will do exactly what they said.
That's a great analogy about changing your oil. You're right. So Julie, what specific things related to affordable health care can we see prioritized probably in the federal legislation as we go on in the next at least 2 years?
So I think that there are a couple of issues we were hoping to see. This is my wish list. I don't know if they'll actually do it. But there are a couple of problems with the ACA, the way that was written. One would probably be the family loophole. So your individual insurance is 9.5% of your income is capped at it, but the family coverage isn't. And so if you have employer-based insurance, you can't get insurance on the exchange. Well, if your employer-based family plan is really expensive and you can't afford to cover your family can't go to the exchange. It's called the family loophole. That needs to be fixed because there's family coverage that, you know, people are making choices about whether or not they can cover their family based on the cost.
So let me back up just a second. So in other words, someone who's working can be covered, but the family may not be?
Well, they could not afford to cover their family because the family plan is not priced at 9.5% of the income like your individual coverage is. But because they have employer-offered family coverage, they couldn't go to the exchange and purchase it because they have technically employer-based insurance.
That is quite a loophole.
It is quite a loophole, and it's really unfortunate because a lot of people will look at their employer-based coverage and the individual-only rate is like, okay, that's reasonable, I can do that. And then you have one child or one spouse, and it explodes, and you're like, oh wow, I cannot afford that.
So Randy, you're federally qualified health centers. How would your organization deal with that if someone came to you and said, well, I've got this much, but not this much, and I'm in a quandary?
Yeah. So the nice thing about FQHCs is that we base all of our rates on poverty levels, and so you can get a very reasonable rate. So I think our lowest rate is around $35. So it's a very reasonable rate, and it's set depending on which part of the country you're at. If you have more, if you have other folks that are in there, you also can look at the poverty level of the entire family, and that is a little bit more beneficial, or it's at least a little easier to be able to get rates that your whole family can afford.
Is there any way going to Nevada HealthLink that they can mitigate that loophole at all?
No, that's part of the problem.
That's the big problem. Right?
But I would add to this conversation that while we're a little bit more hopeful that there may be some bipartisan efforts around policymaking and around the Affordable Care Act at the federal level, you know, and maybe we're thinking that no longer will there be a threat of repeal and replace because the House is now Democratic. I think that it's woefully ignorant of us to not pay attention to the executive branch's policy-making changes that have created all sorts of fracturing in the individual market. And that's an opportunity for our state legislature to play some offense and defense.
And let's get on that subject. Senator Spearman, you are the chair of the Health and Human Services Committee in the state legislature, which is coming up quickly. What might we see prioritized in the upcoming legislative session that I believe starts February, first part of February?
First Monday in February.
Right. Specifically related to health care and affordable health care.
Well, we're going to continue the path that we had last session, which was to make sure that we put in place some things at the state level that would mitigate anything that happened at the federal level that would throw a lot of people off. So what you'll see is us trying to do a little bit better with that. We're going to make some changes with what was commonly known as sprinkle care. I think it's AB 374. And I'll let Assemblyman Sprinkle talk about that because he's been working really, really hard to try to answer the mail on what the Governor Sandoval's issues were last time. I think what you'll also see is some legislation coming forward. We have not addressed adequately the mental health crises that exist in our under 18 population, and connecting the dots between adverse childhood experiences and low achieving schools, food deserts and low achieving schools and that sort of thing. So we're going to be looking at some ways that we can look at this comprehensively. You'll also see an attempt, I know, to make sure that we answer the mail on prescription drug affordability.
Adverse child experiences. What exactly is that, first of all?
Well, you know, unfortunately, 2 days ago, we had a student at one of the high schools here who was shot, and his friends were around him when that happened. That produces a type of trauma that is not easy to overcome. And so children who have experienced traumatic events in their lives early on, there's something that happens with the way their brain develops, and just trying to get over that trauma and make sure that they are positioned to learn, sometimes that is a lot. The other thing that we look at is it's not just what happens to the children, but domestic violence in the home, what they see on the streets, you know, a lot of what they see in the family, substance abuse problems, those sorts of things. And so we found out in our interim healthcare committee that there are a lot of things that are connected to this mental health crisis. We've not even addressed that among adolescents. And so I am committed to making sure that we look at that, connect the dots, and see how we can use our money more and be fiscally responsible, but at the same time make sure we are preparing our children for success.
And we have addressed that on a previous show, and we want to invite you back right now.
Okay.
The session is over to discuss it again.
Sure.
This year's federal tax bill removed the individual mandate. Now, can you explain exactly what the individual mandate is and how this impacts, the removal of it impacts all of us?
Well, if I can be really wonky, health policy wonky, I'm just going to say
sure, that's why you're here.
Yes, right. So the individual mandate didn't actually go away. The tax penalty was zeroed out. So it's still written in the regulation. It's still in statute. But what happened was before, if you went without insurance, then you had to pay a tax penalty,
right.
And that tax penalty has been zeroed out. And what we've done at a state level is really try to get our arms around who will actually forego insurance as a result of there being no penalty. And what we've done is target our advertising campaign toward individuals that we think are going to potentially forego, 26 to 40-year-olds, typically healthy. And we want to make sure that they understand that the price of healthcare is expensive, and you should not go without it because you could bankrupt yourself or your family.
But convincing someone, and that age group you're talking about, a lot of those young people feel invincible at that age and beyond sometimes. How do you make that your case that they should do this?
Well, first you meet them where they are. So we really have been aggressive about our advertising campaign in going to BuzzFeed and digital and social media. We are all over the place. But then you also talk to their moms. Women make healthcare decisions. I can't tell you how many times I've been at an open enrollment event and seen a mother bring her 27-year-old in and say, he needs health insurance, please help him.
Okay. All right, the Review Journal reported that an estimated $3.2 million is going towards marketing and outreach for this current enrollment period. You were just starting to talk about. What populations are you primarily targeting, and what is the message to hopefully motivate not just the younger generation, but everyone to get on board?
Well, first we talk about how expensive healthcare is. I mean, that's one of the things that I think sometimes gets lost in the conversation in health policy is, oh, insurance is so expensive, but insurance is expensive because healthcare is expensive, getting services. You're nodding your head, I'm so glad. And so we're really working on focusing on that millennial target group, but also Latinos and Hispanic population and individuals who are self-employed. So these are people who are, potentially hairstylists or manicurists or those kind of individuals who are working for themselves.
And one of the things that people forget, a single incident in the hospital is $15,000, the average. It can cost up to $25,000. That's a lot to pay if you don't have coverage.
Define a single incident. I mean, that's not a major operation.
That's not a major, that's an injury. You get injured, you go into the hospital, you're inpatient for a couple of days, $15,000. It can be up to $25,000 if you're staying a couple of more days. And so that can bankrupt a person, and that kind of fiscal impact on a person can last an average of 4 years. And so it's not even a short term, this is this moment. It can financially impact you for the next 4 years or more of your life.
Or more, as the senator mentioned, your credit score can be.
Yeah, and I was just going to say, and to that end, we all pay because uncompensated care, hospitals cannot turn away anyone. And so we all pay. When people don't have insurance and they show up at the hospital, if there's a car accident, if they fall and injure themselves on the job, whatever happens, anything can happen. And when they go to the hospital has to accept them. And as one hospital CEO said to me right after Obamacare/ACA passed, was that, you know, I don't want 100% of zero. I'd rather have 15% of something. And so what you have with the ACA, when more people get enrolled, is you have the opportunity for hospitals to start digging their way out of red tape. And a lot of people think that there is a huge margin, profit margin for hospitals, and that's just not true.
You know, it's such a dividing point politically, Obamacare, the ACA, and certainly still is in a lot of political circles. But based on the current elections, the recent midterm elections, the population seems to have calmed down a bit. Is that what you're hearing from your constituents?
I think they become more educated and more literate, and have rejected the notion that because you call something by one person's name that it is automatically bad. And the thing that I said as a veteran, I have government health insurance. Everybody in Congress has government insurance. And, you know, I've always said for those who don't think that the ACA is a good thing, what they should do is they have to abide by the same insurance policies that are in their state. If they are relegated to abiding by whatever Mississippi has, whatever Kentucky has, whatever Texas has, and not what Congress gets, I think you'd see a different conversation.
What are the chances of that happening? Because I think a lot of people are on board with that.
I don't know, but I'm putting it out there. So if somebody wants to start a petition or something like that, but I think, see, when you do it that way and people recognize, okay, wait a minute. So it's not just I can say this and I can do this for political reasons, but it will actually affect me. People need health care insurance because what it does is it gives them an opportunity to go and take care of things before they get bad. Because, you know, if you can see a doctor and do a $15 copay, that's a whole lot better than paying $2,000, $20,000 to get chest x-rays because you think you have pneumonia.
And the individual mandate actually was really for two reasons. One, we want people to have insurance because we want them to have coverage. It's also a financial choice, too. The more people are covered, the larger the pool of people are, the lower insurance premiums are. So there's purchasing power in large quantities of people. The risk pool gets spread out, so there are more people to cover the people who are very, very sick. So when they asked for the insurance mandate to be in, it was both to make sure that the federal subsidies did not go through the roof and it made healthcare more affordable for everyone, and we want people to be healthy. But there actually, the financial piece, I think, got lost a little bit because then it was where you're just trying to make me get coverage. And that's true, but there were two actual reasons why, and one was finances as well.
Okay, Julie and Randy, I want to ask you both the same question. I'll start with Julie. You can have anything you want. What would be the best of all possible worlds to happen to Medicare and Medicaid? Medicaid specifically.
Medicaid specifically? Yeah. That's a tough question. I think greater coverage for mental health. So we cover a lot of outpatient mental health. Inpatient mental health isn't covered. It's not covered at the same rate as health insurance. So if there's a continuum of care for health care coverage, you can get in the home, you can get an assisted living center, you can go into a nursing home or skilled nursing if you need a lot of care for a longer time period. That doesn't exist for mental health. There's outpatient spotty, we kind of cobble together some stuff in the middle, and you can go into the hospital if you need acute care for 15 days. So I hope you get well in 15 days, because that's all that's covered. That's a huge gap.
So I'm going with the ultimate wish. I think that health care should be a right, and I think that we should have health care for all. So if we did that, I feel that our communities would be strong, our kids would be healthy, our elderly would be well taken care of, our veterans would have the appropriate care. It would just be health care for all.
Yeah. Casey, can I just let me just jump in, you know, because I think the veteran population is one demographic that we don't talk a lot about. I happen to be retired, so I get health coverage, but you have some who are in the National Guard or who are in the reserves, and when they're not on active duty, they don't have that same coverage. Right. Of course, they can buy into Hillary Clinton proposed a bill and it passed that they could buy into TRICARE, but if they're swinging from job to job because they continually get deployed, then they don't have that as an access. And so what we're really talking about here is we're talking about people who are on freedom's frontier also having access to affordable health care. And to Julie's point, you know, one of the things that we don't recognize is that when we don't take care of mental health and we don't do that in a comprehensive way, all of us are at risk, because that person who is not on their medication, who can't get their medication, they might meet our sister, our daughter, our mother, our husband. They might meet somebody out there and they're not on their medication, and then it's not just a statistic, but it is actually a person's life who is in jeopardy.
I want to circle back to something that you brought up a few minutes ago, AB 374, Medicaid for All. Governor Sandoval ultimately vetoed it, saying, quote, it was an undeveloped remedy to an undefined problem. Now, what are the chances that that's going to come back up in this legislative session and be passed?
I believe that it will. I believe that it will, and I won't. I don't want to comment on it because I know that Assemblyman Sprinkle has been working tirelessly on that since really before session ended. I think that you will see it, and what we were really trying to do with that was we were trying to anticipate what would happen at the federal level, because you know it was more chaotic than Ringling Brothers, Barnum and Bailey for a while there, and we wanted to make sure that, you know, Nevadans had the care and had access and options to the care that they needed. So I think Assemblyman Sprinkle has answered the mail on that, and I think everyone will be pleasantly surprised.
On our previous show, we touched on gaps to access to affordable health care, particularly the rural, the undocumented workers, the undocumented populations. Basically, we just don't have enough facilities or eligible providers really in this state to reach everyone in our state. So what are some successful strategies that might be expanded across our state? And Randy, I'll start with you on this one.
So certainly there is some loan repayment that are federal programs, and so they do help bring providers to Nevada. The state of Nevada actually does some loan forgiveness programs as well. So if we can expand those, that is critically important. By 2026, the United States will see a crisis in terms of providers, and states like Nevada, New Mexico, Utah, Idaho, Montana, South Dakota, North Dakota, all of them are going to have a lot of challenges recruiting. Nevada's been sort of on the forefront thinking about that, building rural residency programs, so treating or getting residents, family practice residents, trained in rural areas so that now they're comfortable living in a rural center. You're doing some more rotations, you're building some more family practice programs. This is what Nevada needs in order to kind of meet that need.
Planning ahead, what are some of the solutions that you can come up with, Julie?
So we do, we really do look at the Nevada Health, you know, loan forgiveness programs, and we have the J1 visa program for doctors. We used to not have very many. We had 3 there for a while. You can have 30. Last year we got up to 15. I was very excited.
Explain the J1 visa real quick.
So doctors who are qualified and can practice and are licensed in the United States, but they have immigrated from another country, they can get a J1 visa. And we work, the state works with immigration and their employer, and they spend 3 years. They're committed to 3 years in the community, and it has to be an underserved community. And what we find is that they often stay afterwards because they've settled in that community, they have their families. And so it's been actually really great to get more J1 visa doctors, but I think we have to even look beyond doctors, no offense, doctor, into one great innovation Nevada did was to expand practice for advanced practice nurses. So nurses actually have a pathway from being, you know, a certified nursing assistant to an APRN who can practice independently of a doctor. They can have their own practice. They are really on the front lines of primary care. So looking at healthcare extenders, who else can do healthcare besides just traditional doctors? So looking at, you know, spreading that out so that we can access more people.
Is there something the legislature can do to expedite this?
Well, you know, one of the things, and I've just kind of been playing around with this in my mind, and I don't know that it'll come forth as a BDR, but I'd like to call it something like Good Samaritan, and that is we've got loan forgiveness, we expand, we look at the advanced practice nurses, we do all of those things, but the other thing that we should probably look at is housing. If we could look at housing, because the cost of housing is going up, if we could look at things like expanding access even to telehealth. A lot of people don't recognize that the net neutrality that went away has just made it more difficult for people in rural areas to access that benefit. And so I think we should probably look at housing. I also think that we've got to take into consideration that by, I think it's 2040, Nevada is going to be a very gray population, something like 57 to 60%, I think it is. And so as Nevada begins to gray, there will be other things that we must have in place for the people who are coming here that will need those services. So I think we need to start looking at some type of housing subsidy. We should probably look at some type of subsidy in terms of other primary things that people would need in their lives. So we've got to think outside the box.
Outside the box and towards the future, and we have to leave it at that. We'd like to thank our guests, Heather Karbulik, Executive Director of Nevada Health Link, Dr. Julie Kochevar from the Nevada Division of Public and Behavioral Health, and State Senator Pat Spearman, of course, the chair of the Senate Health and Human Services Committee, and Dr. Randall Christensen, MD, the Chief Medical Officer for Nevada Health Centers. Now, if you'd like to learn more about any of the topics we've discussed here on Nevada Week, or if you have a topic or question you'd like us to explore, visit our website, find us on social media, or email the show. That's it for this edition of Nevada Week. I'm Casey Smith. Thank you very much for spending part of your Nevada Week with Vegas PBS.